This is Audible Bleeding, the Vascular Surgery Podcast. We're here to help you keep your finger on the pulse.
Welcome back to another episode of Audible Bleeding. Today we have Dr. Tom Forbes with us. Dr. Forbes is Professor of Surgery and Chair of the Division of Vascular Surgery at the University of Toronto. He was appointed the R.J. Elliot Chair and Division Head of Vascular Surgery at the University Health Network up there. He obtained his medical degree in 1990 from the University of Toronto and completed his general surgery and vascular surgery training at the University of Western Ontario. He's the Program Director of the Advanced Aortic Surgery Fellowship at the University of Toronto, and a joint fellowship between the vascular and cardiac surgery and open and endovascular therapies for thoracoabdominal and aortic pathologies, which we'll talk about later today. He's also published over 200 peer-reviewed papers, editorials, and book chapters, and given over 100 invited lectures and guest professorships. His academic interests include clinical outcomes research, as well as combining engineering principles with complex surgery, and colleagues at CAVE, or the Center for Applied Vascular Engineering, and he's currently an associate editor of the Journal of Vascular Surgery and the Canadian Journal of Surgery, and a member of several editorial boards, as well as being chair of the Document Oversight Committee on the Society of Vascular Surgery. Dr. Forbes, welcome to Audible Bleeding.
Thanks very much, Matt. Thanks for having me.
So I guess we can go ahead and get right into this. Can you start out by just telling us how you came to a career in vascular surgery?
Sure. It's probably a lot different from a lot of people of my sort of generation of surgery. I started medical school. I didn't come from a medical family, but I started medical school thinking I wanted to be an orthopedic surgeon. The main reason was because playing sports growing up, I broke a lot of bones, and my only exposure to a doctor was the orthopedic surgeon who put some metal and plates into me. During medical school, that changed a number of times. At one point, I wanted to be a cardiologist, wanted to be a head and neck surgeon, and because of exposures to early mentors, I then got turned on to trauma surgery. So I actually started a general surgery residency thinking I wanted to be a trauma surgeon. During my first year, my R1 year of general surgery, we had a 3-month rotation on vascular surgery. And at that point, I couldn't have told you what a vascular surgeon did. I mean, this would have been 1992, 1993. I had never had any exposure during medical school or internship. But I, because of exposure to the people I worked with, at that time, the big aortic surgery that they were doing, I was really turned on to vascular surgery, the technical expertise that was necessary, the dedication to the patients. But at that point, I thought about doing a vascular surgery fellowship mainly because I thought it would make me a better trauma surgeon. So after my R1 year, I did a year in the lab when we operated on mice and rats, and it was a ischemia reperfusion injury. And it did some call for the vascular surgeons, finished my general surgery training, and again started my vascular fellowship thinking that I would combine it with my training with general surgery and be a well-trained trauma surgeon. But as vascular surgery fellowship went along, at that time it was the early days of endovascular aortic surgery. I remember in my 4th month of vascular fellowship, in November of 1997, we did our first endovascular stent grafts. As the fellow, I was an observer because the staff surgeons were just trying to figure out what was going on. So I basically did a groin cut down and then stood back. But that was kind of an exciting time where you could see where vascular surgery was going, separating more and more from other specialties, namely general surgery. So even though I started off my vascular surgery fellowship thinking that I was going to combine it with a career in general surgery, by the end of my fellowship, I knew it was going to be only vascular surgery, and I never practiced a day of general surgery.
Hi, this is Adam. I'm wondering, if there were any specific mentors for you and what makes them unique and what drew you to them early in your career.
Yeah, a number of mentors that I can think back to during my surgical training, and these aren't well-known individuals, but I did my training at a very strong clinical program. There were people like the late Murray Girardi, who was a trauma surgeon, who a great mentor during my training. What I remember about Murray is that even if it was 2 a.m. and you were doing the worst case possible, he kind of was enthusiastic and got you turned on to the surgery, no matter how tired you were. During my subsequently in my general surgery training, there was Ed Meads, who he had been a trauma surgeon during the Vietnam War and had obviously a unique experience, and we all looked up to him. John Duff was our chairman of the department at that time and a general surgeon, and he was a role model as well. During my vascular surgery training, 3 people that really shaped me during my training, Ken Harris, Guy DeRose, and Bill Jameson, and those were the people that I spent countless hours with during my training and shaped me as a vascular surgeon. And then I think, in being a Canadian vascular surgeon, nobody can go through an interview without mentioning the influence of Wayne Johnson. And although I didn't train in Toronto under Wayne, I would have loved to have operated with him and worked with him. But as a mentor academically, from leadership, mentorship, I'd be remiss without mentioning Wayne's influence, and now I value him as a senior colleague within our division.
Now, did you succeed him? Was he the previous chair in your division, or was there someone between you?
Sure. So Wayne was the founding chair of our division, and then was succeeded by Tom Lindsay, who served 10 years in that position, and then I succeeded Tom.
And so, were there any risks that you took early in your career, or advice about decisions that vascular surgeons in training could take?
Yeah, I mean, I'll give you somewhat of a funny anecdote, and it was advice that I took, but in retrospect, I shouldn't have took it. When I finished when I was just finishing my vascular surgery training, looking at my first sort of faculty position, I was looking at one job at a major academic center, and I was finishing my fellowship in the summer, and they had kind of a desperate need to fill a clinical void, and they wanted somebody to start that summer. And I thought, well, this endovascular aortic stuff, some Canadian surgeons were going off to the Royal Prince Alfred in Sydney and working with Jim May. I thought, I wonder if I should go there for 6 months, or go down to one of the American centers that were leading and doing this early on. This would have been 97, 98. We had done a couple. Thinking back, it was with the C-arm. You could during my general surgery training, I'd seen the early days of laparoscopic cholecystectomy, and there were a lot of similarities. Those first lap choles, you couldn't tell what you were seeing on the TV screen. The operations took 3 hours, and you'd be thinking, this is never going to fly. Same thing with endovascular aortic work. These C-arms, there wasn't a vascular package. It was difficult to see. The devices, the delivery systems were massive. Trainees today, probably it's a historical terminology to hear terminology like iliac on a stick, but we would see that as we were removing a device. We would tell our anesthesiologist, okay, this device is coming out, hopefully the iliac artery isn't attached to it. These were the early days. So I thought that prior to starting this job, maybe I should go off for 6 months or a year or something, and bring this back and see, kick the tires about this stuff. And the advice, I still remember it as yesterday, the advice I got from the chairman of this department was, well, yeah, I guess that might be a good idea, but this endovascular stuff, I don't know if you really want to stake your career on it. I think it may be just kind of a fly-by-night strategy, and why don't you just start working? And I took that advice, and now I think when we're hiring our new faculty, I want them to go away somewhere, even if they're trainees of ours. I want them to go off somewhere, pick up something new, bring back a different approach, and make the group better. I think it's also part of the maturation process when you have been away for a little before you start your faculty position. I think you feel differently, and maybe are viewed differently when you come from somewhere else.
So you went against someone's advice and adopted and went to learn about endovascular therapy. The benefit of hindsight is very easy to say, oh, endovascular is great, but how do you tell people now about adopting something which maybe in your mind might be a little risky?
I think the times continue to change, and that the oversight is becoming more intensive. I know at our institution, if you're going to bring a new technology, if any surgeon is going to bring a new technology to the hospital, or even do a different operation with existing technology, we go through. You have to give a little bit of a brief to the Innovation Committee. It's not like an REB, but it's basically a presentation before your peers, saying what the risks are, the costs are, how many cases you want to do, and then you have to come back to them with the results of the first couple of cases. I think that's a healthy process. It's not, it's not meant to be a restrictive process. It's just supposed to be a sort of logical look at this new technology. I think there's different ways that groups can apply new technology. One is to hire somebody who's been trained in that environment and then have them train the existing surgeons. And then the other way is through either mini fellowships or whatever is necessary to learn that new technique. And I think our societies, the SVS, some of the global societies are getting better at making people aware of some of these opportunities. They're very topical right now. I don't know if it's hit the press down south of the border, but this week there's been a lot of press up here in Canada about the medical device industry and the lack of oversight and the harm that rapid adoption of new technology has caused some patients.
Yeah, sure. Dr. Forbes, I know you have some familiarity with how things work down here. We've also had a lot of popular press on that type of stuff. But can you talk about some of the differences between, how technology comes to market and how, the restrictions between Canada and the United States?
I'll give you an example. For example, custom-made branch thoracal abdominal devices. I know that's been quite restrictive down in the U.S. outside of a couple of centers, and there's good and bad with respect to our process. So I guess the good is that any vascular surgeon can apply for access to a branch thoracal abdominal CMD for a specific patient. And it's through Health Canada and it's through compassionate use, and that can be done at any hospital. Yeah.
Really? Any vascular? That's interesting. Will they get supported by the manufacturer, or is that a separate issue?
So it's performed by the surgeon. So, for example, if I had never done, say, a branch thoracal abdominal, I had a plan for a patient. Health Canada is not going to ask me how many I've done. They're not going to look necessarily at how many our hospital has done. I send in a 3 or 4 page application saying why can't existing technology be used for this, and within a day or two it gets approved. That was good in centers that were going to do a certain critical volume of cases and develop their expertise. So we've had access to branch and fenestrated technology for 13 or 14 years. Saying that, though, we need to pay more attention, certainly in Canada, to volume outcome relationships and the expertise that's necessary for optimal outcomes. And perhaps we should be, in some cases, a little bit more restrictive.
So has that been examined specifically with related to branch and fenestrated devices in Canada yet, or no? Sort of regionalization of outcomes?
When I think of Ontario, which is our province, which is a population of about 14 million people, so we have looked at population-based data, and interestingly, the volume outcome relationship is much tighter with open thoracal abdominal surgery than it is with endovascular thoracal abdominal surgery. But we are seeing a centralization of these advanced technologies to fewer hospitals, which are then larger volume, for a number of reasons. One is I think there's a general realization that that's the right thing to do from a patient perspective. From the hospital perspective, these are costly initiatives, and not every hospital has the wherewithal to invest in this. And it's not just the device. It's the allied health, the human resources, obviously the physical plant of fixed imaging systems and appropriate imaging, and all the ancillary equipment that is necessary, all the wires, catheters, covered stents, and then the ability to rescue these patients afterwards, whether it's spinal cord complications or major cardiac complications. Not all hospitals have the ability to have a program which is necessary beyond just doing an individual case.
So how many sites do you think are performing custom fenestrated and branch devices across Canada? I mean, I know we've got the consortium here in the US, and I think there may be 13 sites or 14 sites. How many would you say are in Canada?
The population of Canada is only 35 million people. So it's a massive country. So we have the population of California. There's a crazy stat where some high percentage of people live within 100 kilometers of the border. So population is really concentrated along the US-Canadian border. So when we talk about 35 million people, 14 million people, or more than a third, live in Ontario. 5 million live in the Greater Toronto area. So that's 1 in 7 Canadians are really concentrated in a very small area. There are 10 training programs across the country in vascular surgery, from east to west, and graduates of vascular surgery per year would be, not every program might have a graduate. We do have what we call a direct entry, you would call an integrative program. So we do have a 0+5 program that started about 5 years ago, and all 10 training programs do a direct entry program. We also continue to have the 5+2 training program. The integrated or the direct entry program has been quite successful in that it's really been adopted by medical students. Seems to be the way that vascular surgery training is going here, such that the 5+2 is actually becoming less and less popular for training programs, but also for trainees. And such that in my program at the University of Toronto, for the last 2 years, we haven't had a 5+2 spot. We've only been going the direct entry or integrated program route. All 10 training program sites, academic centers, would do either open thoracoabdominal as well as endovascular thoracoabdominal, fenestrated, branched. And then across the country, so that's 10. So then across the country, I'm doing a rough guess here, but probably maybe double that number of some of the non-academic community practices that are doing some of that. So I would say, at most 20 sites across the country.
Okay, so it's still fairly limited.
And do you feel like these are pretty self-regulated as far as, these institutions' ability to rescue the patients or even perform the procedures?
You'd think that there's been enough work done with this technology around the world, with the Europeans, with the Aussies, with the US and Canadian experience in the Far East, that it wouldn't be that difficult to accumulate a global experience, especially since up until not that long ago, it was a single device manufacturer. But the device manufacturer certainly hasn't necessarily seen it as their role to keep track of these cases. And to date, there really hasn't been a huge effort to look at these results from practitioners. Now that we are a number of years into this technology, I think some of the results are probably a little bit more sobering than we think they are, especially when you're talking about the thoracoabdominal technology. If you looked at a composite outcome of spinal cord ischemia and mortality, I think it's probably higher than we would think it is.
And I think that there is still definitely a learning curve. I mean, we have our own IDE here, and we've gotten better at it in the last few years. And so I can imagine that if there are sites doing only a small number of them, the outcomes may not be as good.
And then transitioning in for people to get into this field and maybe get the volume, you're involved in Advanced Aortic Fellowship. What's the role for any advanced training in vascular surgery for specific fellowships versus just going somewhere and getting the experience without a formal framework?
So I can tell you a bit about the fellowship program that we set up here, which is at the University of Toronto, which is what we refer to as an Advanced Aortic Surgery Fellowship. It's at our 3 academic hospitals, so University Health Network, Sunnybrook Hospital, and St. Michael's Hospital, which are the 3 main hospitals of our university division. We work fairly closely with our cardiac surgery colleagues at each of these hospitals as well. So the principle behind this fellowship came a couple of years ago when myself and a couple of like-minded individuals in the vascular and cardiac programs got together, and we recognized that the reality of the training for thoracoabdominal surgery at that point wasn't necessarily complete. For example, if somebody came from a cardiac or cardiothoracic background and wanted to do subspecialty training in thoracoabdominal surgery, then they would go off to a place like Houston and get primarily an open education. And then they would go back to their faculty position. And when they would see patients, they would generally apply open techniques, which would be appropriate for a lot of patients, but maybe not appropriate for some patients. On the other hand, somebody with a vascular surgery background, if they wanted to get advanced training in thoracoabdominal surgery, they would generally go off. Well, back in the day, they'd go to UCSF or Cleveland, or go over to Europe and work with Tara Mastracci at the Royal Free, or Eric Verhoeven, or Stefan Hallan, and again would get primarily an endovascular experience. And they would go back to their faculty position and they'd see these patients and they would apply what they knew best and did well, which is appropriate for a lot of patients, but maybe not appropriate for some patients, namely connective tissue disorders or aortopathies or younger patients or anatomically unsuitable patients. So we thought, if we could develop a fellowship that was open to both cardiothoracic trainees and vascular trainees that explored both strategies. It was a joint open and endovascular fellowship where trainees got exposure and gained expertise in both, such that when they'd had their faculty position, they would have a better idea of applying these different therapies to individual patients. They were more flexible in their approach. We've had our first graduate of the fellowship program was a cardiac background surgeon, Jennifer Chung, who graduated last summer. It was so successful that we kept her, we hired her, and she's been a huge addition to the aortic program. Our second fellow has started as well, and it's really tailoring to the experience to the trainee. So, for example, if the vascular background trainee may have had limited exposure, depending on what program they were on, to some of the chest work, some of the open chest work, or cardiopulmonary bypass, depending on what program they came from. So they may have to start off the fellowship with what might have been seen as sort of a mid-level cardiac exposure. On the other hand, a fellow with a cardiac background may have had limited exposure to wire skills and some of their early rotations during the fellowship may be what you'd think of as a sort of a junior or mid-level vascular exposure, learning some basic guide wire skills so that they then can learn some of the advanced endovascular technology work. So that's the fellowship. I think it's a bit unique in that there is exposure to both. We feel strongly that these are complex cases, and the goal of the fellowship is not necessarily to create a super uber surgeon that can do everything on their own, but it's somebody who can lead a multidisciplinary team, assess patients with your colleagues, and consider all therapeutic options, and then to be involved in a program that can safely apply these therapies to these patients. So that's sort of the history behind it.
That's interesting, because I was going to ask you if you had sort of a milestones-based approach, because like you said, they come with very different skill sets. You're not going to be putting out one specific product, but really someone who can oversee a multidisciplinary approach to the aorta. How long is the fellowship, the Advanced Aortic Fellowship?
When we got everybody down together at the beginning of this and started looking at the nuts and bolts, we had the division heads from cardiac surgery and vascular surgery from the 3 hospitals. We had the program directors from both training programs. And, there were some fundamental questions, like the question you just asked about the curriculum. But one of the fundamental questions for our program director was, is thoracoabdominal pathology, is it a fundamental expectation of a vascular and cardiac resident? Because if it is, then there's not a whole lot of point in having a fellowship if it's a residency level expectation. At least in Canada, and I think a lot of places in the world, it's not necessarily an expectation at a residency level that they would be fully trained in thoracoabdominal work. So, that was interesting. So there was an agreement that it's fellowship level training. And then as far as curriculum goes, there is exposure to both vascular and cardiac, and some cath lab exposure if necessary. It's flexible, dependent on the program that the the fellow has come out of, what their previous exposure has been. It's a 2-year clinical and academic fellowship, so there is a research requirement associated with it. And we're blessed in Toronto in that, at the university is big enough that it's almost anything that they want to explore, they can explore. Dr. Chung, our first graduate of the program, she had an engineering background, so she looked at tensile testing of ascending aortas, matching that with advanced MR imaging, trying to predict patients who would be at risk for both type A and type B dissections based on advanced imaging. So that was her project, and that was a longitudinal project during her 2 years. Our new fellow who will be starting in the summer, her academic interest is more in education and knowledge translation and how to teach surgical skills. So the research platform will be built on that.
And do you feel like this is contributing to the regular vascular surgery and cardiac surgery fellowships, or are these cases being taken away from these trainees?
Great question, because I think that's a constant thing that we have to keep an eye on, is the impact of fellowships on the residency program. And I'd be lying to you if I said everything had been smooth sailing. No matter how many times you sit down with the residents and fellows and you try to clarify the roles, both generally and with respect to specific cases, there have been instances where there's been disagreement about the role of the resident and the fellow, and it's been something that we've been having to navigate. I think our residents probably would be happier if there was not an advanced aortic surgery fellow, because they would get additional exposure. But these cases are complex enough that I think there's 1,000 steps in any of these procedures, and the challenge is to us as educators is to be clear in the expectations at the beginning of a case as to who's doing what steps and to divvy it up. It kind of segues into the whole area of subspecialty in vascular surgery. And because vascular surgery, especially the direct and integrated programs, are relatively new, our other surgical brothers and sisters from other programs have long adopted subspecialties. Very few people, I think, graduate with solely from, say, an orthopedic surgery residency or a general surgery residency without then doing a fellowship, regardless of whether they're entering community or academic practice. I think we can learn from that, but we can also learn from some of their mistakes. I think in some sense, general surgery and orthopedic surgery have subspecialized to the point that there's a lack of generalization. I know at our place, if I'm doing something and I need a general surgeon to deal with a dead left colon, for example, I may be calling the general surgeon on call, and I might be getting, their academic practice or their clinical practice is breast surgery. And they haven't done a colon resection in a while. So I think we have to I think we should explore subspecialty training in vascular surgery, but we always have to remember that generalization is important, and you need to be able to deal with what comes in the door. Because if we ever got to the model that general surgery and orthopedic surgery is, and we said, okay, I'm an aortic surgeon, and an ischemic leg comes in at 2 a.m, but I'm an aortic surgeon, I can't handle that, then we've really failed. And I think that's there are some areas where general surgery and orthopedic surgery that's what's happened.
I think also the other thing is that our current model with the 5+2 and the realities of life, where a lot of them do research and then they do 2 years of residency, it's less likely to do subspecialization. I think it's only become a discussion now with the 0+5s. I think that in practice, most vascular surgeons will have to do a little bit of everything.
I agree with you. I think there's a role for subspecialization, but maybe not at every center. My personal view is that at the larger academic centers, there has been subspecialization at larger academic centers for some time, but not necessarily all the time because of specific training. For example, at a lot of centers, the person who's seen sort of as the biggest aortic surgeon is sometimes somebody who's got a couple of years under their belt and has developed that practice, and not always related to their training. Sometimes it's more related to seniority.
We've been talking about training in focusing and subspecializing, but then what are your thoughts about, should some procedures be centralized at certain locations, and this concept of kind of centers of excellence, and whether centers should kind of demonstrate a certain volume in order to be able to then do those procedures?
That's a really topical question. With my work with the Society for Vascular Surgery, every conference call that we have every week, this comes up. You can imagine some of the differences of opinion with the community practice of vascular surgeons versus academic surgeons. If I can go on for a little bit of a soliloquy here, I think, on one level, with respect to volume outcome, it kind of makes sense. The more somebody or a center does, hopefully the better they're at. However, it's also kind of a simplistic measure of quality, because it sometimes ignores other factors. For example, at a surgeon level, if we were to say, you should be doing X number of procedures per year, well, what about the person who's first year in practice and has done 0? Or the person 20 years in? What do you talk about? What happens about their cumulative experience over years? How do you determine that? Also, at an institutional level, if you're saying a center has to do a certain number of procedures, you sometimes forget about some of the infrastructure and the other healthcare providers that are necessary to ensure quality outcomes. And then, of course, in different healthcare jurisdictions, well, if you're not going to be doing those clinical volumes, well, what's going to happen to the service of the population in that area? At the SVS level, as you may be aware, clinical practice guidelines up until the aneurysm guidelines that were published in January of 2018 in the JVS, none of the clinical practice guidelines had really touched that third rail of volume outcome relationship. And the aneurysm guidelines, which were led by Elliot and a group of experts in the field, came up with a draft proposal initially that, along with a quality metric, that endovascular aortic procedures, shouldn't be done at a hospital that is doing less than 30 cases a year. This was the draft proposal. And then open aortic repairs should not be done at a hospital that's doing less than 18. So 18 and 30 were the initial suggestions. That was based on research, and it was epidemiologically valid. However, when we started talking to different practitioners in different environments, for example, we had some community practice members saying, well, I work at 4 or 5 hospitals. If you're saying that each hospital has to do that number, I may meet that number, but any single hospital doesn't. They thought it was a bit self-serving to larger, predominantly academic centers. There was a compromise such that in that guidelines, compromise between sort of what was academically sound from an epidemiological standpoint to what was practically relevant, such that the final guideline said, pretty modest volume outcome relationships, that open aortic surgery should be done at centers that are doing open aortic procedures, at least 10 a year, or 1 a month on average, and endovascular the same. That still is very hotly contested. You may be aware of, obviously, the Leapfrog initiative, which highlighted 10, 11, or 12 surgical procedures. There was the volume pledge that 3 major academic institutions entered into a couple of years ago. But this is a tough conversation, because the more you peel it back, there's more and more layers to it. My personal feeling is I think volume outcome is important, but it's a start of a conversation to all the other metrics and all the other requirements that are necessary for quality care. Getting back to your question about, do I think that some procedures should be centralized? My answer is, I think yes. Certainly in the Canadian environment, there are not only quality reasons and experience reasons why they should be centralized, but also just simple health economic reasons why they should be centralized.
We always talk about aneurysms and thoracoabdominals. They're sort of the glamorous procedure. But are there other typical vascular procedures you think need to be centralized as well?
Thoracoabdominal aortic work is unique in that there's the volume outcome relationship, but there is also the investment in infrastructure that's required. The other things that we do, yes, there's an investment in infrastructure and in technology and equipment, but not necessarily to the same extent. So perhaps in those cases, rather than looking at volume, we can look more at a quality metric and saying, well, it doesn't necessarily matter how many you're doing, but what's your outcome? You know, at the SVS level, the SVS is under Tony Sadawi's leadership is partnering with the American College, looking at a platform for vascular centers across the United States, similar to bariatric centers or trauma centers. And so the conversation is starting that and well down the path that there might be levels of vascular centers where, along with the type of work that's being done at these centers, there's a link to quality metrics and volume metrics as well.
We're going to pivot a little bit. What are your thoughts about the interconnection between personalized medicine, vascular surgery, and how can vascular surgeons best prepare themselves for the changes that come with personalized medicine?
We've done a little bit of work with this, and it sort of was a bit of a passion of mine over the last couple of years to entertain this. And really what sparked this idea was, you know, I was walking down the hall in our hospital, and the hospital right across the street is the cancer center. And I would walk by this window every day on the way to the ward, and I saw this big poster out across the street that said, you know, personalized cancer surgery, and it was almost a you know, it was a big billboard type thing, probably looking at donors and patients and all this. And I thought, boy, these cancer docs, they talk so much about personalized care and personalized surgery, and I get it, but why? You know, that's what a vascular surgeon does every day. We do personalized therapy. Why don't we broadcast that and use that as a calling card? Because it seems to really resonate with patients, with hospitals, with donors on the philanthropic side, and our cancer guys have sort of figured that out and are using it. So then I started looking a little bit more into what personalized vascular surgery kind of would mean, and you know, one of the first things that might come to mind are things like custom-made devices. Okay, so that's personalized to anatomy, but also part of personalized surgery would be things like using big data and coming up with predictive tools at an individual patient level. And there are apps for that, and you look at any of our journals, there are predictive tools at the individual patient level looking at big data. So that's a personalization decision-making process. We hear a lot about, another opportunity is that we hear a lot about pharmacogenetics, and we know that there's a certain proportion of patients who aren't aspirin responders or clopidogrel responders, even though there's recommendations to put all our patients on these antiplatelets and other medications. If we thought of that from a surgical perspective, you know, a surgicogenetics perspective, we know that through some of the work that Alec Clues in Seattle did, that there are genetic profiles beyond a hypercoagulable state profile where patients just don't do well with percutaneous and either open lower extremity revascularizations. So there is a link to our genetic profile. So that's a personalization opportunity. So I think as a vascular surgeons, that's something we do every day. There are opportunities where we can expand it. And I think we should be raising the flag, saying we do perform personalized vascular surgery. That's what we do every day when we make these decisions. And our cancer colleagues, I think, have probably figured it out earlier than us and have really used it as a calling card.
Dr. Forbes, as some of our listeners are going to go on after this interview and kind of look up some of your research and everything, one of the things they're going to come across is this great video of you telling all your patients to be active. How do you stay active?
Like a lot of us, I guess we're identifying. I work hard. I'm a sort of type A personality. I don't have a lot of time outside of work. My personal mental and physical therapy is through running. I like to run quite a bit. This morning I ran down to the hospital, which is about 10 kilometers as I did rounds. My marathon days are past. I think my joints are starting to ache a little bit more after anything beyond 10K. So, but I did run some marathons. I like it from the physical aspect, but I also like it from the mental aspect. It's kind of my alone time. I can think about everything and come up with a come up with some strategy or even put together a talk when I'm running, or I can think about nothing, which is equally valuable.
Is there anything you listen to when running?
My wife and I have 4 kids, 3 of them that's our daughters, and so I am a big fan of teenage girl pop music. so my running list and my OR list is full of Lady Gaga and Katy Perry, and my musical interests, along with country and western, but musical interests are sort of anything what any teenage girl's listening to. I love that stuff.
This aortic fellowship is sounding better all the time. What about something that you feel is adamantly true about vascular surgery that not everyone or a few people agree with you on?
Yeah, I think I don't know if I would say not everybody agrees with it, but when I think of vascular surgery and vascular surgeons, I remember my wife saying to me when we were when I was doing my fellowship, you got home, and for the couple minutes you got home and you got called back to somebody's OR, some of your surgical colleagues' OR, general surgery, orthopedic surgery, somebody who had gotten into trouble with bleeding. And, that happens every day for all of us, right? But we're kind of like the firemen or the Marines that, you think back to those 9/11 tapes where everybody is running away and these guys are running towards the building or running towards the fire. That's what, vascular surgeons are. They choose the difficult stuff. They run towards the fire. And in a sense, worldwide, there's half a degree of separation between any of us. Generally, I think vascular surgeons are top-notch people who do tough things and work really hard. And these days with technology and communication, people are an email, a phone call, a text away, no matter where they live. If I can tell you one anecdote, I think when I was first starting practice in the late 90s, it was 1999, and struggling and thinking, boy, am I really trained adequately? I'm having some bad outcomes. I'm, a little frustrated. I visited Frank Vieth when he was at Montefiore, and he said, well, let's go do rounds. And I thought, this is great. I'm going to go do rounds, and I'm going to see the magic that he's doing at Montefiore. I'm going to learn these operations that I've never heard about, and he's going to tell me the secret. This is like going to the mount and getting the secret. And so we went on rounds, and I can't remember the specifics, but we'd walk into a patient's room, and he'd say, this is Mrs. Smith, and she's had multiple infrainguinal bypasses, and she developed a graft infection. And unfortunately, this graft is compromised and is likely to go down. And I'm afraid that, at some point she's going to need an amputation. And I thought, man, I've got a couple of those patients at home. And then the next patient was, this is Mr. Brown. And he had a, back in those days, a MEGS procedure.
The Montefiore endovascular graft system. I put some of those in when I was an intern.
Exactly. Oh, that is great. So, this patient had this, but, had a post-op MI and got anticoagulated and then developed a retroperitoneal hematoma and respiratory compromise. And, we're trying to get her through this. And I thought, man, I got a couple of those patients at home. So I tell Frank every time I see him, I say, look, you're not going to remember this, but those rounds were the most valuable rounds that I've been on in my whole career, because I realized even great surgeons and leaders in our profession, like Frank Vieth, everybody struggles with the same things. And this is tough stuff, but it's really a band of brothers and sisters that worldwide is such an impressive group. And I encourage trainees and practicing surgeons, reach out to people around the globe and ask them questions, pick their brain. Because it's really a tight circle.
Tom, I just want to compliment you on that analogy. I really like the idea of the vascular surgeon as the fireman. I mean, I think deep down, everybody goes into vascular surgery because they like being the one called when other people are in trouble and going in and fixing the problem. People won't really admit that, but that's one of the very cool things about vascular.
Is there any closing words or anything exciting that really every trainee should know about, or advice for trainees that you want to leave us with?
Yeah, I think, I'm generally a pretty glass half full type of guy. I think these days there are a lot of stresses that we're all facing inside and outside of medicine. Vascular surgery is a tough love. It's like an abusive relationship sometimes. When you think you're on top of the world and you think you're the best surgeon in the world, that's when your spidey sense should be tingling, because you're going to get kicked in the groin your next case. On the other hand, when you think you're the worst surgeon in the world because you've had that complication, you've got to just put it behind you, learn from it, and go forward. It's a challenging specialty, but it's a very, very rewarding and a very valuable experience.
The interviewers today were Doctors Sharif Alozi, Matt Smith, and myself, Adam Johnson. And we are Audible Bleeding, the vascular surgery podcast. You can find us on social media at Audible Bleeding or online at audiblebleeding.com.